Good afternoon, everyone. It is right at the top of the hour. We're going to wait a couple of minutes for everybody to join in. But thank you for joining the CommWaters AI Ask the Experts Q&A on common problem areas in medical documentation and E&M coding. Or as we like to say, the exciting side of healthcare. Okay, we'll give it about 30 more seconds. Well, to get us kicked off, just real quick, so everybody who's on the live session, AAPC CEUs are granted for you, so you'll get the paperwork post the webinar. So post the webinar, we'll have a couple pieces of documentation coming over to you. Actually, a few pieces. One is a copy of the presentation. Number two, a copy of any questions that are asked during the meeting with the answers. And then any documentation required around the AAPC CEUs. Can we advance one slide? So good afternoon, Joe Ferro, president of CommWaters AI, 30 plus years in compliance and coding and revenue cycle. And I have two esteemed colleagues. Angela?
Hi, my name is Angela Jordan, and I am the EVP of ChartPal, which is the coding documentation improvement division of CommWaters AI. I've been in healthcare for over 30 years, with the last 13 years focusing on consulting and working with groups that were undergoing payer litigation, etc. And thank you for joining us, and I will pass it over to Nancy.
Hi, thank you, Angela and Joe. My name is Nancy Entwistle. I am the EVP of Regulatory and Coding Compliance for CommWaters. I have about 35 years in healthcare up here in the New England area, mostly trauma hospitals, as well as teaching medical centers. So I work with physicians a lot to try to make sure that they learn what we need them to learn so we get better documentation. Joe?
Yeah, thank you. Next slide, please. So about CommWaters, the whole reason for CommWaters was to bring order compliance and standardization to E&M, to the E&M coding process. We sit right at the doctor's desktop. So while your doctor is charting, they hit a button and we automatically level the encounter for them for E&M services. So, difficult process. Not everybody knows what's available, what's appropriate. And we're here both through advanced AI technology to help your providers, help your doctors, but also we have a phenomenal team for education and follow-up services. Next slide. So real quick disclaimer, this is everything we're going to present today is to the best of our ability and everything that we could find and glean that is available today. As everyone on this call knows, what's available today can CMS will joyfully change that tonight to make a change for tomorrow. So always, follow what we're doing, but also make sure, do your own double checking. We think what we have is very highly accurate, but again, the rules are always changing. They're always progressing. They're always evolving. So always trust but verify. One more slide. As we get kicked off in the presentation, Angela and Nancy will take everything from here. One housekeeping item is at the very bottom of the screen, there is a button that says, so if you scroll down, it'll pop up. You'll see a button that says Q&A. If at any time during this presentation, this education session, you have a question, hit the Q&A button and you can type it right in. We will do our best to answer your questions at the end of the meeting, although we have a very full agenda today. If we do not answer live, you will get an answer post the meeting in the packet. But please click the button and ask any questions, any and all. We love your questions, and we'd love to get the answers over to you. So thank you very much. If I can turn this over to Nancy and Angela. Thank you all.
Thank you, Joe. Angela, shall we get this started?
Yes, let's.
All right. What are the documentation requirements for the new CPT code G2211?
All right. Well, in answering this one, I will tell you right now that if you were in like family practice, or you are any what they call the general practices, basically what Medicare has stated in the articles that they put out, the MLN, on how to actually use the code, and in some upcoming education that WPS GHA is going to have on April the 2nd. Basically, what Medicare is going to look for in the documentation is, number one, medical necessity for the encounter. 2, of course, the level of service. And then 3, the documentation must support either that patient relationship where you are the focal point of their healthcare needs, which is actually speaking to your general practice, family medicine, internal medicine, geriatricians, those type of providers that are really the focus of the care. Or you can be a specialist that is dealing with a single serious condition or a complex condition. And those are the keys there. It's going to be a serious condition or a complex condition that's going to require that specialist to actually be more involved with that patient. Now, in reading that MLN, it also states that Medicare is going to look at the data. And when I say data, is the G2211, it implies that there's an ongoing relationship with the patient. So they're going to expect to see claims, more possibly than one, over a year. Where some of the questions have come up is with specialists, where maybe the patient, I'm going to pick on urology right now. Let's just say the patient has a chronic long-term condition, but the patient has gotten to a point where they are essentially stable on their current treatment. And then they might be only seeing the physician themselves once a year, but yet they might be having, quarterly lab work drawn. And there are several of us in the industry are wondering, how is Medicare going to look at those if a specialist is only seeing a patient once a year, billing out that G2211, what that might look at, the coming years from an audit perspective. And I also provided you with a link on the bottom of this slide about which of the other private payers are at this point in time honoring and reimbursing for the G2211. All right, let's move on. Oh, sorry, Nancy.
Just to help everybody understand, could you explain to everybody what the WPS is, in case they're not familiar with that Medicare group?
All right. Good idea. All right. So in this presentation, what we've done is, if we don't have what we need from the AMA, we've gone to the Medicare MACs, which are the Medicare adjudication contractors that actually pay Medicare claims. And so I'll be referring to WPS GHA. There's also NGS, which is National Government Services, CGS, First Coast, Palmetto, Novitas, and Noridian. So you may hear those come up, and those are your Medicare payers.
Great. Thanks, Angela, for that clarification. Can you score an E&M service based on the number of conditions addressed in data?
Well, the answer here is yes, you can. Both the AMA, not only the guidelines, but even the medical decision-making table itself states that you can choose 2 of the 3 medical decision-making elements. Now, I think I know where this question might have originated from. If you remember back to 95 and 97 guidelines, it was really easy sometimes to get a higher level of service based upon a complete exam. And some groups, in order to be more compliant, they basically told their coders, you could only use problems addressed and risk. That's it. We're not going to use the middle ground. That's not the case here. The work is the work in the medical decision making. So it can be problems addressed in data, it could be data, and it could be risk. So there's no certain two that have to be used. All right,
Excellent.
Nancy.
So when performing a pre-op examination, does that automatically meet a 99214? Or would the provider need to be discussing the patient's chronic condition that may cause issue during the surgery?
Well, you are correct. The provider really needs to document the conditions that the patient has, if they have conditions. Now, one thing I really want to drive home here is, number one, no, it's not always a 99214. But the other bigger question, is it really medically necessary? And the reason it's important for everyone to realize, especially those of you that are new to coding, preoperative clearances are normally basically a requirement for a surgery. The patient has to be cleared. It's a requirement. And in some cases, in this instance, NGS, they actually have an FAQ actually addressing this issue, stating that, sometimes if a patient is completely healthy and they're having, a relatively low risk surgery, then it's very possible that that pre-op clearance isn't even medically necessary. And on review, they would deny the claim. And so it's really important when you read this is that there has to be, a risk with the surgery. There has to be identified risks with the patient that are being evaluated in order to get the clearance to actually move forward with the surgery. And oftentimes that clearance may require the patient to maybe stop certain medications that would put them at high risk for bleeding. They may need to do certain things before surgery in order to be at a lower risk. So that is what Medicare and the payers are going to look for in your documentation. That was a great question, and thanks to whoever submitted it.
Excellent. Thank you, Angela. So the next one we're going to be, how about we highlight the number of complexity of problems addressed at the encounters? So a pediatrician believes that strep throat and UTIs are moderate severity. We see these as acute uncomplicated. Can you offer any information on this?
Oh man, I really wish Nancy and I had the answers for this. Just simply because we're not clinicians. Now, some of you online, you might be nurses. We might even have some nurse practitioners and PAs on here. You're probably, better capable from a clinical standpoint to address this. But what is interesting about this is you have to really read the two definitions of an acute uncomplicated and an acute with systemic. And I think the answers are actually kind of in the definitions. And so the first thing you have to do is you have to say, okay, is this condition in and of itself that the patient's coming in with, is there a high risk of morbidity with it? If it's not, then this is the acute with systemic is the wrong one. So what it's really going to boil down to is the physician's documentation, again, needs to really indicate what the risks are to that patient, what those signs and symptoms are. And the other things that really will help out coders and auditors and billers, whomever, is if the physicians actually document their differential diagnoses, what it could possibly be, and the tests and things that they're doing to rule it out. That actually helps to go take that additional. And the other part of the definition, as you see here, is if a patient has general symptoms such as fever, body aches, but they're only treated to alleviate the symptoms of a self-limited or minor problem, then you need to go look at those, because this isn't the correct moderate or acute systemic is not the correct one to use. So to answer the question that was asked, I've seen UTI documentation that fell under acute uncomplicated. But I've also seen UTI documentation in an elderly patient that was having, some additional symptoms. In other words, they were kind of confused and things like that, that actually was moderate or even high because of those risks involved. I've seen strep documentation as low, but I've also seen it as moderate as well with other symptoms. So it's really going to rely on the documentation.
This is one of those areas, Angela, that no matter how many times we think we have it under control, it just isn't always as clear as it should be. And we just highly recommend that you continue to go back to your providers. And the more documentation that they can give us, the better we can, and more compliantly that we can code that out the door. Can you explain acute illness with systemic symptoms? So this seems to be a continuation of our last question. And
Yeah.
what type of documentation would you like to or expect to see for this?
Okay, so with this question, I did exhaustive research. I went out to specialty societies, and I looked through the AMA CPT assistant. I looked through the AMA knowledge base. I even looked to see if any of the Medicare MACs had, anything of substance. Like I said, since Nancy and I are not clinical, but as a coder, especially if you've got a lot of years in this field, there's just certain documentation when you read it, it just like hits you in the gut, oh, okay, this is moderate, or oh, this is definitely high. But in order to try to help during this webinar without having a physician on here to help us out, I found this really great article from the American Academy of Pediatrics and it was What Constitutes Acute Illness versus Systemic Symptoms by a Physician. And I was really impressed by the article because even within her article, she was struggling and comparing the issues from the AMA with these two definitions. And finally, by the time the article is over, she's like, just document based on time. It'd be easier. And I just kind of chuckled. But the AAP, American Academy of Pediatrics, had two really great documents that they put out. They had a primer on E&M coding in 2021 that was, I can't remember how big, it was multiple pages. But then they also had this great FAQ on their website. And so for this question of acute uncomplicated versus acute systemic, these were some of the idea or some of what they listed within their FAQ. So they're saying in a fever, if they've got URI symptoms, in their opinion, based upon the documentation, that's probably low. But if you've got a patient that's got a tick bite and now they've got a fever, in their opinion, that's moderate because that can lead to other diseases. Tick bites are not good. And they gave us some other examples here that from a pediatric standpoint might prove helpful. But what I wanted to do is share with you on this slide, these are all of the specialty society guidance that I was able to find that was actually where they went a little bit above and beyond the AMA grid. And then they actually provided either clinical vignettes, scenarios, or similar lists to what the AAP did with their that might prove helpful. But I want you all to remember one thing about these is, especially on the one for the American College of Emergency Physicians, this is their opinion, okay? And even if on the American College of Emergency Physicians, if you go to the very, very bottom of their FAQ, they clearly put a huge disclaimer on the bottom that basically this is their opinion, this is clinical judgment, and this isn't necessarily for reimbursement. So you have to, when you use these resources, realize it's their clinical spin on what they believe the guidelines intended.
So again, as coders, we just always reflect back to our official guidelines, our AMA guidelines, as well as any legislation that governs how we code.
Mm-hmm.
For conditions that are known to be chronic, such as diabetes, is it necessary for the provider to have stated within the note or the assessment and plan that the condition is now chronic?
Oh, all right. So a couple of weeks ago, if you would have asked me that question, I would have said, well, of course not. If diabetes, it's chronic. I mean, it's inherently chronic. And typically, unless it's, a pregnancy induced or diabetes, or, something that's induced by something else that can actually go away, in my mind, non-clinical here, I would say no. However, during I've been really voting up and listening to all the different MAC guidance, that because now they are auditing E&M services, and office E&M services are right now the #1 cert error. So now all the MACs are actually looking at them. And I know I was just listening to Palmetto webinar earlier this morning, and Palmetto is sending out TPE letters right now, which is the Targeted Probe and Educate for Office E&M Services 99213 through 99215, because the audit results were so dismal. So with that being said, during the WPS webinar, they stated that because the definition for a chronic condition indicates that it is a problem with at least that's going to last at least a year or until the death of the patient, in order for them to say it's chronic, they have to see that in your documentation. And I know you're all going, what? Yes. So this is my thought. If your active problem list is up to date, in other words, in your EMR, if it pulls your active problem, so your diabetes with the true onset date, let's say, January of 2000, and then they're talking about the patient's diabetes in here, they have to look at that entire document. So if they can clearly see the onset date is there, and then you've got this, I would believe, under medical review, you could state, look, it is chronic, because even though I didn't say chronic diabetes, my onset date was January of 2000. So they've had it for 24 years, 24 years now. But where I foresee the problem happening is when you get a new patient that has multiple chronic conditions that come in. And inevitably what happens, and Nancy and I see this all day, every day, is that when they add those active problems to the problem list, it's the date of the service. They're not going back and actually putting the actual onset date of the condition. That's where I see a physician, a nurse practitioner, a PA, whomever's documenting on those patients, if they don't clearly state that the patient's had this for 10 years, or it's chronic diabetes or chronic hypertension, some Medicare MACs may inherently say, may come out and say, well, we don't know how long they've had it because the definition says, and you didn't tell us. So I just wanted to make you aware of that. And I do know right now, I do sit on the provider outreach and education committee advisory group for WPS-GHA. And I do know, based upon our last meeting, that the MACs are now getting together to align basically all of their FAQs on the documentation they expect to see. Just want to make you aware of that.
Angela, can you remind everybody how far back the MACs and Medicare can go on an audit?
Well, typically they can go back 7 years. I mean, or, I think they can even go back further if they feel there's fraud involved. But what they're currently looking at right now is they are looking at evaluation and management services that were provided after the E&M guidelines went into effect. So that is what they're looking at currently, and that's why the error rate is so high.
Excellent. Thank you for that clarification. Amount or complexity of data to be reviewed and analyzed. What do we got on this topic? Would a parent providing a history for a 16-year-old be sufficient to qualify as an independent historian?
No. And the reason why is the documentation really, again, going back to the definition of what an independent historian is, the documentation has to indicate why that 16-year-old is not a reliable source. So, most 16-year-olds, if they go to the doctor, they can clearly state why they're there. But if there is an issue, such as maybe they're developmentally delayed, maybe they were in a football and they got concussed and they really don't know what happened, things like that, it would have to be clear to whomever is reviewing that documentation why that, maybe mother provided information for that 16-year-old was either necessary or was it needed to be confirmatory. In other words, the provider needed to talk to the mother to make sure that's what happened. The documentation has to reflect that. So, and I think this is really important because working in pediatrics, we've got doctors that, it's a 6-month-old baby and they just put, it's a 6-month-old and they think there's automatically an independent historian. But the problem is Nancy and I both read notes where the note doesn't document who brought the patient, who's in the room with the patient, and it looks like the 6-month-old gave the history.
Mhm.
So you can't just assume that if you've got a 6-month-old, the history was provided by the parent. The documentation really needs to indicate, patient presents with mother who stated, blah, 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 blah,
Yes.
blah. Or, history provided by mother or history provided by father, caregiver, you name it. So the documentation, again, needs to support the definition and it needs to indicate why the person giving the history is unreliable.
And this is similar to the chronic diabetes. As a coder or as a reader, you can theorize that this would be chronic or that a 6-month-old cannot provide this history. However, it has now become very clear that this all needs to be documented as to why you are accepting information from the parent, caregiver, or representative in that meeting. So that's where the new world of this is heading, that we definitely just need it documented. For any test that requires official interpretation and has their own professional component, such as an EKG, can a provider make that decision to count their independent interpretation under medical decision-making instead of billing for the professional component?
When this question came in with registration, this is one that kind of immediately at my core, I went back to, you document on the claim or you submit the services that you actually provided. And so in my brain, if you're doing an EKG and you're doing the professional interpretation, then you have to bill the CPT code for the global service. And then I think where this stemmed from is from the fact that, remember now in the guidelines under data, if you do an independent interpretation of if you view them and you do your own independent interpretation, you get credit under data. So this popped up with emergency medicine. And so I did some research and the answer kept saying the same thing. And so I was still feeling a little queasy about it. So I reached out to our Medicare MAC, WPS, and asked them the same question. And then come to find out, they even addressed this question in their E&M documentation webinar that they did. It's basically, it's a business decision, they said, because if you're not billing it, then it can go towards your data for your medical decision making. It's one or the other, but you have to make the business decision. Well, in the ED, this is a huge business decision because, if they bill that professional interpretation, it's just a few bucks. I mean, it's not much money at all. But if they put that independent interpretation into the data for medical decision making, From a 3 to a 4 or 4 to a 5, you're talking a significant amount of money. So from an ED perspective, it makes sense then not to bill the professional interpretation, but rather get credit in the data. And, some of your offices out there may be thinking the same thing with maybe your EKGs and your x-rays as well. What is the most advantageous from a business standpoint? Do we want to bill for it, or do we want to count it as part of our medical decision making? Okay, moving on, Nancy.
Moving on, risk of complications and or morbidity or mortality of the patient management. So we have a question that was sent in. What if the provider has a smart phrase in their documentation that is used for every patient for risk? Can we use that for every patient if it is the same exact sentence?
Okay, I'm going to tell you right here that if Medicare or even any payer identifies a trend where every patient, and let's just say in this example, is high risk due to a smart phrase that has not been edited, they will be questioned on it, and it will most likely trigger an extensive review. And the reason I say that is because I did work with groups that were under either UPIC audits, the Unified Protect, those audits from Medicare, some different types of audits with Medicare, where they came right out and stated that issues like this were identified. And then when our company got involved and we went in to try to help defend the client, we saw the exact same statements for every single patient across every provider that had not been edited and were not unique to the patient. And there was really, in certain cases like this, where if every patient is high risk, there was really no way to defend it. And so copy paste and carry forward, and some of they were used in EHRs, or they were put in EHRs to try to make things better. But in hindsight, as coders, auditors, we see the problem it has now created. And so when smart phrases, macros, and I know there are other different terms and phrases for different, EHRs, what they call them. It's really important that when they are set up, that it provides a little bit of information, but it requires the provider to complete it. In other words, that way, so it is unique to each patient. And I will give you a perfect example of something that I recently ran into in working on a case. Every document that I happen to look for, and this is for psychotherapy, every patient across every provider had the exact same psychotherapy statement with the exact same therapy time. And that is if a payer were to get a hold of that, that would send up a red flag, and that would require an audit most likely. So it's never a good thing to have something that would affect the level of service that isn't editable and unique to the patient. I mean, what do you think, Nancy? I mean, have you seen issues?
I absolutely have. It's almost like, when we all went back to school and they could tell when you were, copying off of your friend's paper. If you had the same exact sentence in every single page, the teacher always knew that you were doing something funky. So I think that the way technology is, they almost have to just run it through an algorithm now and determine how many words are actually equal at the same point from one given provider. So I would caution definitely against the same statement not editable, as you had said, to make sure that it is true and unique for each patient.
Yeah. And now I understand that I'll pick on orthopedics here. Now I do understand that there are certain surgeries that always have the same risks. You know, there are, you know, they always have the same risks. So I can see where a provider might have for a certain surgery, you know, these are the risks for this procedure because it's going to be the same. But again, are there any patient risks that are
Exactly.
unique? And if that's the case, they maybe need to elaborate and say, okay, but here's our surgical risks, but there are no patient identified risks, or patient risk is moderate due to, you know,
Age.
anticoagulants, blah, 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 you know, et
Mhm.
cetera, or they're diabetic, or they're a smoker, which you know, increases the risk. That's what I'm talking about unique patient identifiers. The surgical risk, a clinician would argue, it's going to be the same surgical risk, but
Mhm.
you got to look at that patient. What are their risks that might make this either high, moderate, or low? And now,
Exactly.
if that is there, in addition to the macro, then your micro or your smart phrase might be okay. But if it's just the same smart phrase without all of that additional information, I don't know that it would pass.
Especially if you have patients of varying ages with the same exact patient risk. You have a 35-year-old and an 80-year-old. Obviously, the patient risk is greater for an 80-year-old. So you definitely want to make sure that differentiation is made.
Mhm. Okay.
Regarding prescription drug, everybody's favorite topic these days. How do you determine the risk of medication?
On this one, we're going to break this down a little bit. And I'm like, I'm going to go back to each of the MACs. Like I believe it's an NGS on their website, and I believe CGS on their websites. They have FAQs where they address and they kind of bullet pointed out what they expect to see in order to get prescription drug management. And the reason I want to break this down this way is because Aetna, for those of you that know, on their medical, they made their own little medical decision making grid up. And renewing medications, on just renewing or continuing medications from Aetna, from what I understand, I've not seen this grid, but I've read articles about it from people I trust. They have renewing prescription medications as low. Well, then when I was listening to this Encore Evaluation Management E&M risk question and answer session that WPSJJ did, they basically said the same thing. And afterwards, I kind of challenged them on it. And I sent, you know, what the AMA had, I sent what CGS and NGS had. And I said, you know, why are you, you know, taking this stance? Well, what they are referring to is there is an FAQ out there from the AMA, and it was an FAQ that came out after their webinar advancing the E&M guidelines for like 2023, I think was the name of the webinar. So there was an FAQ that came out, and it was a really interesting FAQ where the person that asked it said, look, could you give us some help on prescription drug management? Because, you know, as coders, billers, educators, we need to find a way to kind of basically level set so that when we're educating and we're coding, we're all basically doing it the same way. Because if not, it's difficult. And of course, we want to be compliant. Well, the AMA came out with their response, and they're like, well, look, sorry, guys, there's no blanket statement. And then they elaborate on, you know, what they felt. Well, when you read it, it implied that, you know, there's a higher risk when you prescribe a new medication, when you consider adding a medication, but then because of shared discussion, you know, you don't go with that medication. There could be a higher risk when you discontinue a medication. But when you're renewing medications, if the patient's doing well, that might not be that moderate risk. It could essentially be lower. And I think what's happened is WPS, in their interpretation of the guidelines, because again, what's in the grid for risk, they kept saying these are only examples. In their interpretation, simply refilling medications, even if you address and assess each condition, in their view, simply refilling medications is not moderate risk. So somebody else then came back and basically answered, or asked a question, well, but there's still risk involved. If I've got a patient that's on multiple medications because they've got multiple chronic conditions, that doesn't lessen the risk of the medication. And then basically what WPS came back and said is, look, the provider needs to document, and this is what their medical director called, the provider must document their proof of thought. So basically, why refilling these medications that they've been on for the last 5 years? Why simply refilling them is really moderate risk versus low. So I just wanted you all to be aware of that. Again, I think if you are in either NGS's territory or you're in CGS's territory, still up on their website is there, if you are addressing, assessing, and you are refilling the medications, et cetera, so on, they're saying even if you continue, they consider it prescription drug management. Novitas had one, but they removed it. So if you're in Novitas, they might be reworking their stance on prescription drug management if it's being looked at right now through the MAC collaborative work group. And so basically, I think this is going to be the biggest issue with why the CERT error rate for E&M services is so high, because I think providers out there looked at the grid and they consider everything. Anytime they prescribe something, it's always going to be moderate. But from a clinical standpoint, in hindsight, and based on what the AMA has put out in their guidelines, not every prescription prescribed is going to be moderate. In one of their CPT knowledge base articles, a patient or someone had asked a question about urgent care. And they said, well, what if a patient comes in to the urgent care with strep throat and we end up giving them, an antibiotic? And would that automatically, they said, well, would that be automatically a level 4 because it's an undiagnosed new problem and it's prescription drug management? Well, in the knowledge base from the AMA, they said, well, number one, no, it's not an undiagnosed new problem. It's an acute uncomplicated. And then they went to say, and a short-term antibiotic would not be considered prescription drug management, which kind of caught my attention because I'd never seen it documented anyplace else. I've only seen it in knowledge base. So
bottom line, there's going to be more changes coming through on prescription drug management. We just want to make sure that everybody is aware that these aren't our rules, but they are out there and they are heavily being looked at.
yes.
If a consulting doctor makes recommendations about medication, but the attending actually orders it, who would get the credit?
Okay, again, back to documentation. So that specialist, if they've assessed the condition and the patient needs to be on the medication and they're not actually prescribing it, they're going to have their attending prescribe it. That consulting physician actually is the one who made the decision that the patient needs to be on this. So as long as the documentation shows, again, the proof of thought for that medication and why they need to be on it, it appears based on what I have learned and what I've heard to this point is the consulting physician, the consultant could technically get credit for that prescription drug management. But then on the other hand, when they're seeing their, let's say their attending physician, and they're the one that is actually now making the decision, what they're going to be looking at the documentation for is what did the provider do? What medical decision making, what risk is documented for now that attending physician actually ordering it, you know, whether it be in the office or, you know, in the hospital setting, for them ordering it, and what is the risk at that time. So again, going back to documentation, what does it say and what does it tell us? And then is where you're actually going to determine who should get credit for this.
Excellent. Can you clarify the decision regarding hospitalization from column 3, risk of complication and or morbidity or mortality of patient management of the MDM table?
Okie dokie. So luckily, both NGS and WPS GHA have the exact same verbiage on their FAQs for their E&M services. And in Medicare's opinion, you can only escalate the hospital level of care if you're starting in the hospital, because a decision to admit a patient is going to come from the provider that's deciding to admit the patient. Because remember, it's to either admit or to escalate care. So if you're escalating care, what they're saying, either the patient is in the ED and then they're going to be admitted as to observation, or they could be admitted to inpatient. It could be ED to the ICU. It could be inpatient to the ICU. It could be observation to the ICU. But what they're looking for in the documentation is the decision, who made the decision to move the patient up to a level of hospital care. So which I know there's another question that we have coming up that, you know, that we get asked all the time. But just from a Medicare standpoint, just be aware that that escalation of hospital level care, the patient either has to be in the ED or in the hospital, either inpatient or observation status. And a decision is being made to move them up. And think about it, it could even be an issue where a patient is inpatient. Let's just say it like in an acute care hospital, but the patient needs really highly specialized treatment. Maybe they need to go to a burn center. Well, that's an escalation of care because you're moving them from your little acute care facility to a hospital with a burn unit. So the documentation would need to reflect that type of a transfer because it was needing a higher specialization of care. All right, let's move along.
And here is the question that you were anticipating.
Yep.
If the patient is seen in the clinic or office setting and then transferred to the emergency room, is that considered high risk?
No, not necessarily. And I'm glad because this one I know is asked all the time.
All the time.
All the time. So CGS, Noridian, and WPS GHA, all three have the exact same verbiage for their FAQ. It's back to the documentation. The medical decision making in your documentation has to show your intent. So are you sending them to the ER to be evaluated? Or are you full well sending them there because you know they need to be admitted? So when you're documenting that assessment and plan, the documentation really needs to be proof positive that this is what you think is going to happen. You know, and a good example of that, I'm going to pick on urgent care right here. So urgent care, patient comes in with abdominal pain. They do a KUB, they do a few lab tests, and, you know, they can't really go any further. They can't really rule out this or they can't rule out that. So they say, hey, look, we don't have what we need here. So you really need to go to the emergency room and have it evaluated further because, we need to rule out it could be an appendix, or we need to rule out it could be, stones, or, whatever. In that instance, you're not sending the patient to be admitted. You're sending them for an evaluation. Now, on the other hand, I had a case the other day where this mother brings her 7-year-old daughter in who is having an asthma episode that is requiring nebulizer treatments, required fluids. The provider stayed with that patient the entire time they were there. After the nebulizer treatments and some additional medications, the little girl started to improve, but then she started to go back downhill again. She was, getting lethargic. They were concerned about her going into, acute respiratory distress. The provider gets on the phone, they call the ambulance, they call the emergency room, and that provider stayed with the patient the entire time. And the documentation literally showed the intent of this little girl to be admitted. So that is what the payers are going to be looking for in the documentation. By you sending them to the ED, what is your intent?
Yep. Can a provider document the risk, for example, patient is moderate risk for complication or morbidity?
You know what? Yes, they can. And if you actually really read the E&M guidelines and kind of look at some of the wordings in the FAQ the AMA uses, they are saying that the physician needs to document the risk. Now, they can prevent, documenting the risk in detail, another clinician can understand. But they also go so far to state as, physicians use these terms, low, moderate, and high. Those mean something to the physician. So they can certainly use those words to document the risk. The patient is at high risk. And in some specialties, I think it's more inherent that they actually use these terms. They use low, moderate, or high risk for, either the problem or for the actual risk to the patient. And during some of the webinars, like I said, again, some of the MACs actually even state, yes, we would encourage the physician to just come right out and say, okay, what is the risk? What is the risk to the patient? And I think if we could let providers know that that's acceptable, I think it would kind of ease some of the heartburn that we have, trying to understand and level correctly the first time. And I think it would help with heartburn with payers not understanding maybe from a clinical standpoint what the provider is trying to get across. But if they would have had that detailed and then say the patient is at high risk, I think that would maybe stop some of the down codes that are going on and maybe stop some of the, the appeals that are having to take place where then the physician has to go back and say, well, no, the reason I said this is because the patient is high risk because of this. So again, I just think maybe there's just a few simple things that maybe we could work with our providers and just different key areas where if we could get them to understand the importance of simple terms like chronic versus acute, life-threatening, bodily function, things like that. If they could just work those in certain places, it would make not only their life easier from a payment standpoint, it would certainly make, our lives easier. And maybe when a payer gets your documentation, they're not going to be so apt to down code you because it's just not clear to them.
That's absolutely accurate. So we've provided some references from today's presentation on this last slide. And again, as Joe had said at the beginning, a copy of the slide deck as well as your AAPC CEU will be granted as long as you have attended 45 minutes of the live session. However, I'm looking and we have almost our entire presentation list that has stayed on. So thank you, everybody. We did get a couple of questions in and we are not going to have time to actually get to those today, but we will include those answers as well.
Yes.
And you've submitted some great questions, everybody, so we appreciate that for your participation in that. And Joe, do you have any final words?
No, just to thank you all for your time and effort, and thank everybody for joining, and hopefully we're able to impart some useful and interesting information. If you have questions, concerns, issues, please reach out to us. We'd love to be a trusted resource for you. So thank you all very much for your time.
Thank you,
Thank you,
everyone.
everybody.
Thank you.